Telehealth Summit, brought to you by the California Telehealth Resource Center. We're glad you can join us for today's session on how COVID changed telehealth and what's next. I'm Sylvia Trujillo, the Senior Director of Policy and Advocacy at Ocean, and I'll be your moderator today. A couple of housekeeping items. Today's session is purely for informational purposes. The California Telehealth Resource Center has no relevant financial interest, arrangement, or affiliation with any organizations related to commercial products or services discussed during the Telehealth Summit. And before we begin, I wanted to review a few tips for the WAHOVA event platform we're using today. WAHOVA makes it easy to access event features using a web portal or a mobile app. Explore the agenda to view upcoming sessions, use the community tab to view topics and start or engage in conversations with other attendees. This is a highly valuable feature. We urge you to use it. Also, be sure to check out our sponsors who supported this event and view their offerings. Make sure your profile is up to date. Other attendees will use this network to engage with you. And note, today's session is being recorded and will be available to view through the event platform by next week. Lastly, please feel free to post your question in the WAHOVA chat window. We'll hold the last few minutes of this session for Q&A. With that, I'd like to introduce you to our guest speaker, who I'm thrilled to introduce, Dr. Jack Resneck, who was elected to become the president of the American Medical Association just this past June. Dr. Resneck was elected to the AMA Board of Trustees in 2014 and served as its chair from 2018 to 2019. He's also the former member of the board of the American Academy of Dermatology and the former president of the California Society for Dermatology and Dermatological Surgery. And he's currently a member of the editorial board of the Journal of the American Academy of Dermatology and serves on the board of directors for the National Quality Forum. And he is also a professor and vice chair of the Department of Dermatology at UCSF and holds a joint appointment at the Philip R. Lee Institute for Health Policy Studies. Before I turn it over to Dr. Resneck, I do want to share an anecdote about the tremendous work he has done as a physician and as an advocate for patients and the healthcare system more broadly in the context of telehealth and digital connection to all communities. Very early in my acquaintance with Dr. Resneck, he played a pivotal role in working with the American Medical Association House of Delegates and their leadership to modernize and update the organization's telehealth policy. He also was a tireless advocate in front of Congress, federal agencies, to advance sound telehealth practices and policies that really paved the way for the nation's ability to pivot the telehealth services when we were in the greatest need of it at the outset and through the COVID-19 pandemic. It is hard to overstate the central role that he played. And so with that, I'd like to hand it over to Dr. Resneck.
Thanks, Sylvia. Let me just start by thanking the CTRC for the work that you do, and Sylvia, you in particular, for your leadership over many years. You've been a passionate advocate for telehealth as well, so always a delight to get to work with you. Next slide. And one more. So as president of the AMA, I can't really start any talk right now without reflecting back a little bit on these last couple of years. And as I think about this time period we've been living in, it has been a tough couple of years for the profession of medicine, for healthcare workers broadly, who have really put their lives on the line. I still can't forget images from early in the COVID pandemic of doctors and nurses and others sleeping in tents and in their garages to protect their families. And since then, facing misinformation and disinformation, and even sometimes threats of violence just for doing their jobs. A shout out from me to healthcare workers who have been holding together a healthcare system that has been stretched far too thin, sometimes I say with duct tape, and really suffering burnout as a result. But there have been a few bright spots in these dark couple of years, and one of them really has been telemedicine, which I think of as just a giant success story when I think about the progress these last couple of years. Next slide. When I think about the contrast from where we were 2.5 years ago and where we are now, let me just sort of paint a picture, and many of you experienced this, of where we were before COVID with telehealth. We had, across multiple specialties and around the country, really cool things happening in the telehealth space, but they were very difficult to scale because of a lack of insurance coverage to support them. So, Sylvia mentioned I'm a dermatologist in the San Francisco Bay Area. So I would have patients who would come from hours away, drive to come and see me, even though I work in a fairly urban area of people coming from more urban, rural areas. We'd settle on a diagnosis, maybe do a biopsy, and it would just have made so much sense for their follow-up visits to be done via telehealth. But in many cases, their insurers just wouldn't cover that follow-up with me. So they would have to pile in the car, take a day off work, arrange childcare for their kids, miss hours driving back and forth, pay for parking in San Francisco, all of the challenges when telehealth would have made sense. And sometimes their health plans would cover telehealth visits with sort of an isolated external provider who didn't have their records, didn't know the patient, didn't have access to their history, but they wouldn't cover follow-up with me. So that has really changed as coverage exploded in the emergency, right, following the beginning of the COVID pandemic. And now we've been able to really integrate telehealth as just a seamless part of the healthcare delivery journey for our patients. We've also been able to really advance our knowledge during this time period about when is it best to use telehealth. In my own practice, for example, that patient I mentioned who maybe got put on medications for their psoriasis or their eczema or their other dermatology problem, a follow-up visit for addressing their medications makes a ton of sense to do via telehealth. Another patient of mine who might have a melanoma a year ago who needs a full body skin check to assess whether they have any new skin cancers, maybe telehealth's not the best option for them. So we've really learned a lot across every specialty about when it's best deployed. Patients have benefited from this. They've seen, as I mentioned, improved access, convenience, and the resolution of a lot of those problems around access, transport, work, childcare. And I think we had a sense before that this was most important in rural areas, and it definitely is important in rural areas. But we've seen access inequities also in urban and even suburban areas where it's made a huge difference for patients to improve access via telehealth. The last thing I'll say about this is it's really been useful to be able to deploy telehealth where the gaps in care are most significant and where it's needed most. I think some of the earlier growth in telehealth had been really around convenience care, and really for some subsets of patients who maybe already had good access for care, but now to be able to use it in chronic diseases like hypertension and diabetes and substance use disorder and mental health, where some of the access problems are the most significant, has just been a huge leap. Next slide. AMA's really tried and worked to be at the forefront of this transformation, whether it's early on actually through the CPT editorial panel, actually establishing the codes that are necessary to capture the work, advocating with Congress and commercial insurance plans early in the pandemic for coverage expansions, establishing really the ethical and quality standards for delivering telehealth, creating playbooks like the one in this slide that physicians and healthcare systems have used to efficiently deploy telehealth. And really, I'll talk a little bit later about another effort of ours to insert an equity lens throughout the process as we think about expanding access. Next slide. So what do we need now at this point, 2.5 years into this big growth in telehealth, to do to continue that journey that we're on? Next slide. I mentioned earlier that we've been dealing with a healthcare system that's stretched quite thin, and physicians and others have been holding it together. One of the things that I've been talking about and that the AMA has been talking about the last month or so is what we're calling a recovery plan for America's physicians. And it's kind of how we frame a lot of the work to transition to a healthcare system that really can support physicians and patients as we move into the next decade. I bring it up because one of the 5 pillars of that recovery plan is exclusively focused on advancing telehealth to maintain coverage and payment. Next slide. I should briefly mention before I continue with this, kind of for those who aren't as familiar with the AMA, where does our policy actually come from? And it doesn't come from me. I don't get to make it up. My board doesn't get to make it up. It doesn't come from our management team or our staff. As Sylvia mentioned at the outset, we actually have this large House of Delegates where hundreds and hundreds of physicians, really from every state in the country, from every specialty you can imagine, from urban and rural areas, from small practices and very large healthcare systems, every political leaning from blue states and red states come together and have evidence and science-based debates around our policy and actually ultimately vote on our policies. So moving ahead through the next few slides, when I say the AMA policy supports X, Y, or Z, you just will now have a sense of what that means and where that's coming from. We really do represent the profession broadly. So for Medicare beneficiaries, even though we've seen this substantial expansion in access to telehealth, and you may have heard about this yesterday, but we still face a significant threat that when the public health emergency ends at some point, several months after that, all of these expansions that we've seen for Medicare beneficiaries to be able to utilize telehealth just vanish into thin air. And we go back to the world we were in 3 years ago, where Medicare patients, unless you lived in a very specifically designated rural area, and unless you came in to have your case presented by a healthcare professional from one site to another, really couldn't use telehealth at all. So that's a pretty big threat that we could go back to that. So we need action from Congress to avoid that. They did pass a bill which actually will extend telehealth coverage for Medicare patients for 5 months after the PHE, the public health emergency, is allowed to end, but a permanent fix is still needed. We at the AMA have supported a couple of bills, in particular the Connect for Health Act and the Telehealth Modernization Act, both of which will permanently end some of these restrictions. Just about a week and a half ago, we hailed the House side actually passed another bill called the Advancing Telehealth Beyond COVID-19 Act on July 27th, which will give us a few years of extra runway. And if the Senate would take that up and pass it, that would be very helpful. Next slide. There are also some gaps in licensure policy, and this may come up in the Q&A, but the AMA still supports state licensure so that patients have protections if they have concerns about the care that they've received, and so that doctors know the rules of the road. But there are some very reasonable exceptions that we have supported and that need to be codified, where it makes sense to take care of a patient across state lines in a place where the physician may not be licensed. And fortunately, the Federation of State Medical Boards, also known as the FSMB, this spring took up and unanimously passed a model policy for telehealth, which is now going back to all of the different state medical boards and state legislatures for consideration, that would actually codify all of these exceptions. And we supported that FSMB model policy entirely. I'll just mention a few of those exceptions. So one of them is one that essentially already exists, but would be more codified in state rules, which is physician-to-physician consultation, where a doctor in one state continues to take care of a patient, but uses telehealth for a physician, oftentimes a specialist or subspecialist in another state, to do a consultation, but the prescribing and counseling is still done by the licensed physician in the state where the patient is. Another exception that we're seeking is for episodic follow-up care for established patients, so that if you see a patient in a state where you, as a physician, have a license and establish a relationship that way, but then the patient is temporarily traveling, let's say a teenager who's off in college, somebody who's traveling for work or on vacation, or a snowbird who happens to temporarily be at a home in another state, that it's reasonable to continue to take care of established problems with that established patient across state lines. Another one is prospective screening for complex referrals. This often comes up where a patient is considering coming to another state to go to a center of excellence, often for subspecialty care or oncology, other issues. And this basically allows for one screening visit for the patient and the physicians to see if it makes sense for the patient to travel. Similarly, carve-outs for follow-up care after travel for a big surgery or a big medical consultation. And lastly, around clinical trials, there are some reasonable exceptions. Next slide. We also, at the AMA, have been working to codify requirements to address some quality gaps that we sometimes see in telehealth where needed. Every once in a while, we do run into telehealth that's maybe less evidence-based. You'll sometimes see websites out there providing telehealth where you literally take the medications that you desire, including antibiotics and other things, and put them in a shopping cart, much as you would do at Amazon. And then just at the end, fill out a questionnaire that sort of justifies the things that you're requesting. And that's being called telehealth when it's really not telehealth. So we have tried to shine a light on those because we want the fantastic high quality telehealth that's happening around the country to be preserved and advanced and not be affected by some of these other things. So when we talk about this, we're not talking about a higher or different standard for telehealth versus in-person care. We're really talking about applying the same standards because telehealth in and of itself is not a form of medicine. It's really just a way to deliver healthcare. So we talk about things like transparency, making sure that patients know who's at the other end of their telehealth visit and what the credentials of that person are. We talk about a meaningful iterative history. So when you see a patient in person and you're taking a history and you're asking questions, the patient may give a response, and then that makes you think of a follow-up question. And that can be done via telehealth, whether it's live interactive or whether it's store and forward with a back and forth iterative process. But that capacity needs to be there for telehealth to be a real medical care delivery, as opposed to sort of a static questionnaire. We talk about images being available, whether via live video or the ability to upload, store, and forward. There are times, which I'll mention later, when audio-only telehealth is appropriate, but when the standard of care would call for images via live or uploaded images, we think that's important. And the same is true for ancillary services. And again, you can do all of this via telehealth, but the ability to get labs or radiologic studies locally where the patient is important when the standard of care demands it. And lastly, it's really important to us and embedded in our ethical practices that telehealth be coordinated and not fragmented care, so that when patients get telehealth, their electronic health records preferably, and that those can be shared with the rest of the patient's healthcare team. And that when you try and do a telehealth visit and it turns out that the patient does need to come in for a procedure, for a biopsy in my specialty, for example, that whoever is providing the telehealth actually has local connections in the places where they're providing telehealth so that they can arrange for that urgent in-person care when it's needed. Next slide. So I mentioned earlier that we really work to bring a health equity lens to this. And one of the things that's in our AMA policy is a recognition that access to broadband is really considered a social determinant of health. And I think I probably personally didn't realize until the COVID pandemic and I started doing a lot more telehealth, just how many patients still don't have, in some cases, a device that can allow them to do telehealth, but in many more cases, broadband access. And I, again, live in a large urban area, but I'm surprised that patients who sometimes are just an hour away from where I am really don't have access to high-speed broadband. That's been improving with the Recovery Act lately, but is still an issue. And there are a lot of things on our list that are important to consider as we expand telehealth to make sure that it's functioning to actually improve inequities in healthcare and not exacerbate them. So, for example, and again, these are things that could be true with many new technologies. Coverage. So we need to make sure that we continue Medicaid expansion so that more and more patients have access to healthcare, including telehealth, and that telehealth gets included in those health plans. Audio only. So audio only telehealth is seldom a first choice for physicians and other healthcare professionals providing telehealth. But again, there are times when patients just don't have another choice. when they can't utilize the technology that we're utilizing, where their broadband gives out at the last minute and we need to use a telephone as a backup. So, in my opinion, a telehealth service that is exclusively using telephone services is probably not, in most cases, living up to standard of care, but having coverage of telehealth, audio-only telehealth as a backup is really, really important. And then lastly, not permitting insurers to require use of telehealth. So while it's on the one hand incredibly important that we get telehealth coverage cemented and preserved in insurance company coverage, it's also important that they don't tell certain groups of patients, hey, we're going to insist that you only use telehealth, or that you use telehealth first and we're going to take away access to other types of care. We want patients and physicians to be able to make these decisions about what works best for them. Next slide. So this is probably a good moment for me to mention health equity and AMA's broader work in health equity. Next slide. In 2019, the AMA actually created a large and growing Center for Health Equity to address what we saw as just appalling inequities, especially for Black and Brown and Indigenous and LGBTQ populations around the country. Next click, please. We hired Aletha Maybank, a physician who has been an outstanding leader of that Health Equity Center since 2019. And we really think of it as an organizational home for our health equity work. But I would consider it not to be a success if all of our health equity work was really just housed in that, or siloed in that center. So what's been really fantastic to watch is how this work has been embedded across the organization and our medical education efforts, and making sure that we have a pipeline of future physicians that actually looks more like the populations we serve, and curricula in medical schools that teach people and future physicians to actually go out and battle health inequities in their communities and in the places where they work. And our advocacy work, our litigation work, our chronic disease work, our innovation work, as we're talking about today. Next slide. The Health Equity Center released last year in 2021 its plan to embed racial justice and advance health equity across the organization. And in medicine, it's rooted in science and evidence. And I encourage you to Google it and look it up to get a sense for the broad work that we're doing in this space. Next slide. As I said, there are a lot of components to this, but just to illustrate what this looks like for us in the innovation space, and I'm going to talk about digital health now a little bit more broadly, and it includes telehealth, but also augmented intelligence and e-health apps and other parts of the digital health space. One of the things that we did was recognize that we are not going to have all of the content expertise about innovation and equity and innovation within our organization. So we went out and found experts across the country and formed an external advisory group around health equity and innovation. We also created a unit called Inful Health, and Inful Health was created to push equitable innovation across the innovation ecosystem, because we were seeing many examples across that ecosystem of entrepreneurs and innovators and funders who had an interest in making sure that their tools that they were developing actually advanced equity, but also didn't have expertise to do that. And so this is an effort to engage industry itself in thinking about who are the right people to have at the table, the right people to make sure that they're advancing equity. What are other opportunities to invest in innovation and equity? And it's been a great engagement that's beginning again across the ecosystem. Next slide. As I said, new technologies don't automatically, just because they're fascinating and cool and there's hype surrounding them and they have good intentions in many cases, don't always turn out to help health inequities. And sometimes they can even exacerbate things, again, if we don't think about this from the beginning. So this is an example from a couple of years ago that you may be familiar with, but this is a major insurer with, in this case, good intentions, who set out to create an AI tool that would comb through claims data and medical records when it could, and try to identify patients with chronic disease who were likely to get sicker in the next year. And the goal was to direct more resources to those patients in that year so that you could help prevent hospitalizations and prevent those patients from getting sicker and prevent harm. But AI tools are often a black box, and they learn based on the data that you feed them. And in this case, the AI tool was learning from past years' experience about who actually utilized healthcare resources and what the predictors were. And not surprisingly, there were race ethnicity predictors of who would utilize healthcare resources that got baked into what the system learned. So when somebody, after this tool had already been out in use and was being used on millions and millions of patients, somebody did an experiment where they put the exact same patient characteristics in, the same chronic diseases, the same healthcare experiences, but just changed the race of the patient. And it turned out that this AI tool would direct all of the resources away from the Black patient and towards the white patient, because it had learned, again, just who had access to care and utilized healthcare in previous years. So that tool is no longer in use, but it's just an important reminder that we need to think really from the outset as we are building, whether it's telehealth, whether it's e-health apps, whether it's AI, as we're building tools, to think about and hypothesize about how they can also do harm, so that we figure these things out up front and avoid those harms. Next slide. And I'm just going to close with a few comments before we open up to questions about how we think about driving the future of medicine, again, beyond telemedicine, as we think broadly about innovation in healthcare. Next slide. We have seen at the AMA, so I showed this AI example a minute ago, but if you go back a little further and think about tools that physicians are using now, like electronic health records that the vast majority of physicians have in their offices. When they came out, there was really widespread dissatisfaction among end users, largely physicians, that those tools probably were not designed by people who were on the front lines and seeing patients and knew what we actually needed. So as a result, you see studies like this one showing that for every hour that a physician spends face-to-face with a patient, they are now spending 2 additional hours managing things like electronic health records and sitting around at night after they put their kids to bed, actually putting in health records, health information, because those tools are inefficient. And they've gotten better, but we had to go back and reinvent them in the subsequent years. And that really could have been avoided if there had been more end user input up front. Next slide. If we see this with e-health apps too. There are really, really amazing, wonderful e-health apps being developed, and others that are not so wonderful. If you go to the Apple App Store and put in blood pressure on any given day, one of the top apps that still comes up is one that tells you that if you just hold your finger over the iPhone camera or put it up against your body, that it'll give you a blood pressure reading. And maybe someday we'll be there, but we're not there yet with that technology. So patients are essentially getting great random number generators and driving their health in that way. Coming back to my world in dermatology, there's a lot of cool stuff going on in AI, particularly some of the low-hanging fruit is around recognizing lesions like melanomas and figuring out which moles actually need to be biopsied. Again, great idea, and one that will eventually be very helpful in assisting those of us who are taking care of patients and figuring out which spots really do need biopsies and potentially saving some other patients who don't need biopsies from getting them. But again, the tools learn from the teaching sets that you feed them. So this is one where a tool was out in practice and helping people decide which lesions to biopsy. But it turned out that the teaching set had discovered that among all the melanomas that were given to it, a majority of them had surgical markings, like you see the purple lines in this photograph here, and a majority of the benign moles that it was given did not have surgical markings around them. So if you submit the exact same mole to one of these tools with and without purple lines or black lines around it, it will give you a different likelihood of it being cancer. So again, hypothesizing up front. And this comes back to telehealth and the reality that we've got fantastic, wonderful things across specialties going on in telehealth, but we also have an explosion on the internet of telehealth aimed more at hair growth and other issues that come up for patients around convenience care. Not that those things can't be taken care of by telehealth, but it's probably not where the biggest gaps in care are, again, and where we need the biggest growth. So one of the things that we did at AMA was to create a unit called Health 2047, which is based in Silicon Valley out here in California. We created it in 2017, and the idea was to ensure that the physician perspective is represented early in innovation cycles. You can advance a click here. And the Health 2047 has already spun off a number of companies that we're quite proud of that are doing some innovative things. First Mile Care in certain communities is now bringing actual diabetes prevention programs to patients kind of in a democratized way with an Uber-like app where they can get their coaching at the last minute in their communities when they're available and figure out who's nearby to work with. Zing Health is actually a Medicare Advantage plan focused on patients who have chronic diseases like hypertension and diabetes, and proving that health insurers don't need to chase away sick patients and actually can purposely recruit and find great ways to take care of patients with chronic disease. So with that, I'm going to close. Looking forward to the discussion and questions that come up. And thanks again for being here and for the opportunity to talk with you today.
Great. Thank you, Jack. And apologies, we started a little bit later than planned because I was reviewing your introductory script. So apologies to our audience as well. So we have quite a few questions that have come in both during the presentation and in advance of the presentation. So I will run through those, and I just want to ask the CTRC team if they can ensure that they give us a time check if needed in the chat. So I'm going to start out with Dr. Resneck. Early on in your presentation, you had mentioned that there is going to be congressional or has been congressional action vis-a-vis Medicare. So we're not talking Medi-Cal. I want to make sure our audience is clear that we're talking, we have some questions that are Medi-Cal related, but in the context of Medicare, the legislation that passed the House that would extend many of the Medicare flexibilities for 2 years. But could you tell us, one, the AMA's anticipation of whether or not you're hopeful that that legislation will make it through the Senate and be signed by the president? And if so, when?
Yes, well, my crystal ball is a bit blurry these days, and so I try not to get into the business of predicting exactly what Congress is going to do. But I'm optimistic in general about this. I think, I got to testify at a congressional hearing a couple of months ago. In my conversations with lawmakers, I think there is broad recognition of the benefits of telehealth, and I don't think there's an appetite for, ripping away this benefit from Medicare beneficiaries. It's always a little challenging to get these things across the finish line and passed and to a president's desk for signature, but I'm reasonably optimistic. There are some issues that sometimes come up as Congress thinks about permanent extensions of this. One of them, again, is, and coming back to, do we include audio only or not? And we think they should. Questions about, is it just for established relationships or can you create new relationships via telehealth? They sometimes bring up concerns about fraud, although there's really no evidence that there's significant fraud on the telehealth side. So there are things we are working through with lawmakers to make sure. But when you look at the House vote, I don't have the numbers in front of me, but it was overwhelming and bipartisan in support of this 2-year extension bill. So I'm optimistic we'll be able to get it through the Senate as well.
Great. So I'm going to take some of our late breaking questions. And the first is from Aiden Clark. Is there funding or support for small size practice startups in telehealth?
You may know more about this, Sylvia, than I do in terms of where we stand with grants and the work of your resource center as well in terms of actual financial help for small practices. I mean, let me just say first, from the physician perspective, one of the most important things is, at the end of the day, telehealth, there are some technological requirements and sort of early setup requirements, but we have found the biggest blockade to practices being able to move forward with it is dependable, knowing that in the future, you're actually going to get paid for the ongoing work that you do. So that has been the most important thing. It has been really important to sort of think about helping physicians and practices get set up on the front end. And Sylvia, you have anything you want to?
Yeah, I think, Dr. Resneck, in our own state here, California, we're very fortunate that a House of Delegate member, the California Medical Association, was really quite successful in getting passed in this year's budget. It's actually next year's budget, but it passed this year, funding for health IT modernization. And to your point, however, it's not sufficient to have the technology, and that's health IT sort of broadly. It encompasses the many forms of health IT, but certainly small physician practices, the onesie, twosies, threesies, or practices in underserved communities that don't have really significant margins in order to make a major investment in a health IT modernization. Will need those additional resources to modernize their health IT systems that will enable more easily integrated telehealth delivery options as part of their both full spectrum offerings, but also really essential to engineering workflows. And to your point, Dr. Resneck, it's ultimately, however, whether or not there's sustainable payment and reimbursement for the delivery of those services. But I think the state of California can take a victory lap for the good work that a major member of the AMA, the California Medical Association, has played in those funding priorities. So with that, quickly segueing to another topic, there were discussions and have been a tremendous amount of interest and discussions around the role of social determinants of health impacting the ability of patients to access video only, either because of the type of device that's required, the data plans, broadband connectivity. So thinking through the requirement for interactive video versus audio, what is the questioner here, Mindy K, asked, what should be the standard? I think is one question, and I think you touched on that, but also really related to it from an equity lens, what type of commitment has the AMA made to ensure that audio only remains a critical tool available to practices, especially those in the safety net, that they can be assured that they will be covered and paid for audio only, given they disproportionately have patients who have been identified as having social determinants of health that impede access.
It's a great question and a really important one. So I'm glad it came up. I think all of us in practice have run into this, some more than others. Again, in my practice, sometimes I have done telehealth visits with farm workers in the Central Valley who got referred to me for a skin disease, who literally were on a cell phone during a break, during work in an agricultural setting. And that was the option we had, right? Was audio and that was critical for them to be able to have that option to do an audio only thing. And, of course, we would try at a follow-up visit, because it's important for me as a dermatologist to maybe see their skin, to try to have photos uploaded if we could. But it's still better than nothing to have that audio visit. And in some cases, it was a follow-up visit where I didn't even need photographs. So that's incredibly important. And I think this, as the questioner brought up, happens more often for marginalized and minoritized communities. So there is an important equity issue at stake here in terms of preserving the ability to do audio-only visits. I live in the Bay Area. It's a very tech-savvy area. I wouldn't want to make any assumptions by age or generation. I have 95-year-olds who are quite savvy in being able to use telehealth with me, but not everybody is. So even beyond just having devices, having broadband access, I have times where I'm set up for a video visit with a patient, and it becomes clear right at the time of their visit that they haven't been able to figure out how to get their camera working or something else. So we switch to an audio only visit as a backup plan, and being able to bill for that to maintain that access is also really important for practices, and especially practices that, again, take care of more marginalized populations. So we've been speaking up at AMA. I have mentioned this in congressional testimony. It's in our comment letters to Congress. It's important in our advocacy around bills that we've spoken up for. It's been important in our conversations with HHS around both Medicare and Medicaid populations. We talk to major commercial insurers about this as well, that audio only needs to be preserved as an option. Again, I think when I look at a telehealth provider, sometimes some of the more corporatized ones where if 90% of their visits are via audio, there may be opportunities there and to improve that. And that's probably an important thing to look at, and as maybe not the best telehealth. But this is so important as a backup option that we are going to continue to advocate for it.
Great. That is a perfect, I think, entree to another equity-facing question, and that is as it relates to state Medicaid programs. So earlier we were talking about Congress acting with regard to flexibilities being extended after the COVID-19 public health emergency terminates. Many states have already moved forward, including California, to sunset many of their flexibilities. At the same time, their legislatures have, like California, moved forward to codify some of those flexibilities. However, last summer in California, it became evident that initially the administration, the governor's administration, had decided to not extend flexibilities with regard to audio only. And after really tremendous advocacy and data-driven meetings with the governor's office, the department, DHCS, and with many members in the legislature, this year's budget bill does extend in the Medi-Cal program coverage for audio only, and in particular for F2HCs and rural health clinics, which had been zeroed out in the prior budget. However, it is our impression that across the country, there continue to be many states that don't have the same stakeholders and advocates that are able to provide the type of information to state Medicaid directors with regard to the value of telehealth flexibilities in the Medicaid program and audio only. And what priority does the AMA have with regard to intensive engagement with state Medicaid programs as a measure of advancing equity and access as telehealth being the tool?
As you described, it's incredibly short-sighted, we think, for states not to continue this access to telehealth broadly for their Medicaid populations. And as you noted, we've seen a variety of approaches in different states, and we have advocated loudly and worked with our partners, the state medical associations across the country, to make sure this happens. It's important from an equity standpoint, obviously. It's also just not smart even from a state's financial standpoint, because we have good evidence now about telehealth being an outstanding way to provide care in certain situations. And again, ripping that away, there are patients who are not going to be able to get some of that care, who will not be able to get time off or the things they need to seek it in person. And those patients will end up presenting sicker and later, and worse health for them and their families, and at higher cost ultimately for their state Medicaid program. So it just doesn't make sense, and we are going to continue partnering. This is harder in the Medicaid space because as hard as it is to get a bill across the finish line with Congress for the Medicare program, doing it individually in 50 states for the Medicaid program is even more difficult. So we're also looking at opportunities at the federal level both in terms of legislative and regulatory approaches to also help make sure that this is easier to get done, but we'll continue fighting for this.
So now we have some questions that really relate to the structure, the evolving structure of care teams and the extended care teams. We know that the clinician shortage, nurses, physicians, other allied health professionals is deepening. And we are also facing an increasing demand at a time we have record burnout due to the convergence of 3 public health emergencies: COVID-19, the opioid crisis, the mental health crisis. And as we think about technology and the care teams and what new care teams might look like, we have some new potential care team members that are making their entree onto the sort of center stage of virtual care. And we have a question from Betsy Portillo along those lines. She shares she was recently hired as a bilingual virtual care rep offering live, over the phone and in-person technical support to patients. Question: how critical would you say this role is for providers, and do you see positions like these growing in demand? I'm just going to tack on, in addition, are there other roles or other positions you see evolving as we reimagine and rethink healthcare delivery? How is that good, and what do we need to protect against?
Yeah, so I'm guessing that the person asking the question, who's the bilingual virtual care rep, is talking, when they say technical support, I don't know if that means, helping patients to actually get onboarded and engaged in telehealth platforms, doing interpretive services once they're on them, or actually providing clinical care. The third thing might make me a little more nervous, but it sounds like the first two, and that's fantastic. And it's actually one of those things that it's quite, that telehealth makes even more possible. So I have, in my system that I use right now within UCSF, right in my telehealth platform, I have access to interpreters who can very easily join and be on board with myself and the patient at the same time. It just works really well. And so broadly thinking about that care team, whether it's around interpretive services or additional technical support for patients across languages, that's really important. And I think telehealth also, just like in-person care, allows us to work in really efficient, high-functioning physician-led teams. So we see practices that utilize nurse practitioners and physician assistants and others who are engaged in patient care, doing fantastic telehealth, working alongside a physician who is able to supervise and be engaged in their care. So that can work really well via telehealth also.
Great. Yeah, it sounds like you nailed exactly what it is. And so, Dr. Resneck, though, do you see other emerging positions growing, new roles for care teams? And I think, and what I'm thinking about is community health workers, which are a really important, growing and important member of care teams. And how do you see that fitting in to the role of virtual care and virtual support for patients where they are in the community?
Yeah, I think, this is just one more tool, I think, in our toolbox when we think about providing sort of wraparound comprehensive care for patients' health needs and their medical problems. And we now have growing evidence around what it takes to do that well. And if you're going to manage patients, especially with long-standing chronic diseases, congestive heart failure, diabetes, hypertension, that bringing together multiple members of a care team, being able to do some level of remote patient monitoring, uploading, whether it's basic things like weights and blood pressures, or more complex remote patient monitoring with more complicated medical tools. Again, being able to do that without always having it involve visits to come in and review data is very effective, and being able to utilize members of those healthcare team nutritionists, other people who are engaged in the patient's diabetes management, with the physician being able to see in an electronic platform all the different things that are happening, the ultimate outcomes, and how the patient is doing, and being able to identify those patients, again, who maybe need a bigger intervention and who are not getting those outcomes that we're looking for in terms of their health status. This is allowing this to move forward. We continue to need advancement in those technological tools, right? You can imagine with all of this data that are being made available now that you can get data overload, and that a tool that just uploads 350 blood pressure readings as an Excel spreadsheet to a physician's electronic health record, maybe not so helpful, but a tool that can actually look for trends, engage multiple members of the team, engage the patient themselves and their care can be really effective.
So here is a question that I would encourage the individual who presented it to also reach out to CTRC, because it's just the type of question that CTRC is set up to help an individual navigate through. But the question is, what is the most friendly health IT platform for psychiatrists? And presumably, what factors should be considered and what resources are available to help answer that question?
This is one where, yeah, I mean, I certainly am not in the business of supporting individual companies or platforms, and I'm not associated with any platforms. And this is one of the areas where the AMA really looks to our colleagues in specialties across the country, because they bring up an important point that sometimes what works well for one specialty is not the same thing that's going to work well for another. So in mental and behavioral health, it might be a little bit different than in ophthalmology, where just very different things are sort of needed in that interactive system. So I don't know, Sylvia, do you have thoughts about plugging into those resources?
Yes, I absolutely agree with that. I also might tout not only the work of the CTRC, which is designed to be vendor agnostic. It really provides toolkits to help the analysis of a practice to find the one that's right for them. But I also know of the extensive work that the AMA team does, really a team dedicated to developing toolkits and content around innovation and adapting innovation into clinical practice. So I would also flag that too.
I think that team does a great job of, and it's in our telehealth playbook about as an individual physician or other healthcare provider, thinking about what are the questions you need to ask when you're looking for one of these products, and what are some of the things that might be important tools to make sure that you have. And on the other end, one of the things that our team tries to do is actually make these tools better. So whether it's through regulatory approaches or through working with vendors, trying to make sure that those vendors hear the needs of those of us who are on the front lines, both physicians and our patients, to make these tools work better, and pushing them to integrate those needs as they really think about user-centered design.
So we have the 10-minute warning. So I know this is a question that is one of your favorite questions. And you touched on it earlier in your address, and that really has to do with licensure. And I'm going to elaborate a little bit, having now worked for and am working for organizations that have very limited resources, really face tremendous lack of access to specialty care, finding providers that are willing to accept Medicaid coverage, and where the lack of access is really pronounced. So merely saying, we have lots of doctors in California who are readily available to provide services, isn't necessarily true for the safety net. And licensure and credentialing are both costly, they're complex, and they can be tremendous impediments to finding clinicians who are willing to serve, for instance, the safety net, and do it in a way that doesn't divert really limited resources away from community health clinics, FQHCs, rural health clinics, and other providers who just simply do not have the margins to pay the extra amount of a second licensure obligation in another state, where you may be able to find specialists who are willing to take the reimbursement rate and coverage of Medi-Cal programs are discounted amounts for those who are uninsured. So I think that is one example that is rarely, I think, addressed. And so we now know licensure can be flexible, but what are the long-term solutions to licensure to both streamline the process, lower the cost, both for the provider, the individual clinicians and the providers, but while still maintaining accountability?
Great question. There's a lot in there, so maybe I'll try and tackle all these in separate elements. Let me just first acknowledge that we do have there's a physician workforce shortage that is exacerbating access to care, and that's true for in-person care, telehealth, kind of across the board. And it's been exacerbated by, I think, burnout in the wake of COVID. And, we're now looking at 1 in 5 physicians saying they're likely to retire in the next 2 years. So we have a workforce shortage to solve, and we need to expand residency training positions. So that's sort of a longer term solution and issue there. I think access across state lines, let me just first say, before I even get to the licensure issues, it's complicated. And we don't want, in particular, from an equity standpoint, to say, okay, patients with Medi-Cal or patients at federally qualified health centers are going to get a lesser standard of care. And while it is possible with telehealth to practice across distances and to coordinate care, I also want to say that's complicated and hard work. And so it's not always the top line solution when we face these kind of problems. So if you're getting your healthcare from 2,000 miles away, even if it's from somebody who's licensed in your state, in dermatology, about 30% of the time, I end up needing to see a patient in person after a telehealth visit. Again, whether it's for a biopsy or a lesion that needs to be excised or frozen off or treated. And so you really, in many ways, have to have coordination, at least with local communities, to do telehealth across long distances. And it's a very different, complicated, hard thing to do. So and I guess the other reason it's not a magic solution is because while we don't have enough physicians here in California, I don't know of a state in the country where physicians are not busy and are twiddling their thumbs waiting for something to do. This is really a national problem of a workforce shortage, even though there's certainly some geographic areas that are worse than others. Sometimes we hear about, so there are things we can do to make it easier, right? And I talked earlier about some of the exceptions, especially for patients where it's a physician consultation, or where it's for follow-up care for a patient who's traveling. There are also ways that physicians who do want to do interstate care can get licenses in multiple states. There are still some things we need to fix about this, but Sylvia, you and I were very involved in advocating for the Interstate Medical Licensure Compact, which unfortunately is not an option for California physicians right now, but we need to hopefully get that taken up in California and across the finish line here. But for more than 30 states across the country now, physicians who are licensed in one compact state can, without having to send their lifetime of transcripts dating back to college across state lines, and can actually get licensed in multiple states much easier. It's still costly, as you mentioned. So we are pushing state medical boards to actually reduce the cost of that and have lower fees. We're also trying to get HRSA to extend a licensure portability grant program to help with that. But at the end of the day, we still think having the physician licensed in the state where the patient is important to protect patients. And I'll just say, as a California physician, I have patients, if they were suddenly able to get care from, let's just say, a physician in Florida who wasn't licensed here, and they had a concern that they had been harmed through that care, it is now all of a sudden the patient in Florida can't just go to their Florida State Medical Board to file a complaint because they have no jurisdiction. They have no investigatory authority to be able to even look into that. And the patient would have to come to California. That state licensure also really sets the rules of the road for physicians through state medical practice acts. So that physician from Florida, if they didn't have to be licensed in California, wouldn't have to follow any of our rules around reproductive health care access, end of life care, age of consent. There are so many different rules like that. And another option that sometimes comes up is people say, well, why don't we just federalize all of that? Well, I don't really want the US Senate setting all of those rules for California either. I'm a little worried about where some of that might go. So I don't like the idea of preempting sort of state responsibility to protect the health of their citizens. And there just isn't an equivalent federal infrastructure for that patient who now has a concern to kind of go to Baltimore or Washington to get their complaints heard. So we still are strong believers in state licensure, but we believe in codifying these exceptions, and we believe in making it easier through things like the Interstate Compact to get licensed in multiple states. And getting all the way back to your original question, yes, there is an access problem. We are working aggressively we have increased the number of medical school positions dramatically in the last several years. We need to now translate that to residency positions so we can get all the way through the pipeline and get more physicians in practice in this country.
Well, I want to thank you, Dr. Resneck, for taking the time today to meet with us. But I think equally, if not more, probably more important, is all of your work over easily a decade to make it possible for so many of us to access telehealth.
We have partnered a lot on this work, Sylvia, so thank you to your years of leadership in this area. And again, another thank you to the CTRC for all the work in our wonderful state of California to help us put telehealth into practice as physicians and to help our patients get access to sort of seamlessly integrate this into their broader healthcare. It's great work, and I appreciate it.
Thank you. And that brings us to the end.